On behalf of my co-authors, I'd like to thank the organizers for the opportunity to present our study of survival implications of prescription opioid and benzodiazepine use in lung transplant recipients, an analysis of linked transplant registry and pharmacy fill records. We'd like to thank the funding sources for our pharmacoepidemiology work, including a grant from the National Institutes of Health, and we have no industry disclosures related to this work. So the background for this work is that patients with end-stage lung disease may receive opioids for pain or dyspnea, and some may manage anxiety with benzodiazepines. But limited data are available on the outcome implications of opioid and benzodiazepine use in the lung transplant population. To date, we've examined associations of prescription opioids with outcomes in several categories of solid organ transplant recipients. For example, we found that high-level prescription opioid use before kidney transplant is associated with increased risk of death and graft failure within the year after transplantation. In the liver transplant population, we found that prescription opioid use in the first year after liver transplant was also associated with graded increases in subsequent mortality. And more recently, in the heart transplant population, we found that prescription opioid use level in the year after heart transplant was associated with graded increases in subsequent mortality compared with no use. It's also being recognized that the opioid crisis is related to more than opioids alone. Benzodiazepines have been recognized as a contributing factor in 30% of opioid-related deaths. And in the lung transplant population, patients may have dyspnea and anxiety that may be treated with opioids or anxiolytics, raising concern for the outcome implications of these medications. So the goals of this study were to quantify prescription opioid and benzodiazepine utilization before and after lung transplantation in a large national U.S. sample of lung transplant recipients, and to examine associations of pre- and post-transplant opiate and benzodiazepine use with subsequent mortality. Approaches to studying substance and medication use can include surveys and chart review, which may provide granular information, but can be limited by reporting bias or small samples. And by comparison, administrative data like pharmacy fill records and medical billing claims may offer non-obtrusive measures that do not rely on self-report, though generally lack information on indications and context. And our study utilizes this latter approach to large sample epidemiology. So this approach is grounded on linkages of the National Transplant Registry with other data sources that combine the value of confirmed patient status, clinical outcomes, and exposures captured in the registry with these non-obtrusive real practice measures. We sampled adult lung transplant recipients in 2008 to 2017 who had linked pharmacy fill records in the year before transplant. Our exposures of interest comprise pharmacy fills for benzodiazepines and opioids in the year before and after transplant. Opioid use was categorized as morphine equivalents and then ranked as approximate quartiles per prior methods. Benzodiazepine fills were classified as short or long-acting agents, and we also identified patients who filled both preparations in the evaluation. We identified 11,568 eligible lung transplant recipients who represented 62% of U.S. recipients in the study period. Of these, 34% filled an opioid prescription and 26% filled a benzodiazepine prescription in the year before transplant. And after transplant, 40% filled an opioid prescription and 18% filled a benzodiazepine prescription. And the highest level opioid prescription use was more common among women, Black patients, and patients with lower education or public insurance. Higher level opioid prescription fills were also more common in patients with lower functional status or higher serum creatinine or dialysis requirement and who underwent transplant in more recent years. There was evidence of co-prescribing, such that benzodiazepine fills were higher among patients with the highest level opioid fills. And there was also evidence of persistent filling patterns after lung transplant, such that patients who filled opioids and benzodiazepines at higher levels pre-transplant continued to fill at higher levels after transplant. Finally, with regard to outcome, lung transplant recipients who filled both short and long-acting benzodiazepines before transplant had 2 times the mortality compared with no use in the year after lung transplant, independent of opioid use. Pre-transplant opioid fills were associated with mortality, but the associations were not significant after adjustment for benzodiazepine use. And with regard to post-transplant use, fills of short and long-acting benzodiazepines during the first year after transplant was associated with a 77% increased mortality in the subsequent year after transplant. Further, highest level post-transplant opioid use was independently associated with 2-fold subsequent mortality. And these associations were independent, although interactions were not observed. So limitations of this study include that the design can identify associations but not prove causation. We were unable to account for non-prescription drug use and lacked some clinical measures due to the limitations of what is captured in the registry. But strengths of this study include that the design is grounded in novel linkage of large databases that may overcome some of the limitations of self-report or of study of small select samples. So in conclusion, although associations may in part reflect underlying conditions, prescription fills for opioids and benzodiazepines before and after lung transplant are a marker for increased risk of post-transplant mortality. Further, many patients receiving pre-transplant opioids or benzodiazepines will continue to fill these agents after lung transplantation. And so we believe that further work should seek to identify underlying mechanisms and also assess the feasibility and outcome implications of decreasing opioid and benzodiazepine use in this population through other strategies for symptom management. And we thank you very much for your engagement with our work and your attention, and we wish you a wonderful rest of the Congress.